Hello and welcome to my channel. My name is Peter Abraham. I am a registered nurse with experience in cardiology, med surg, long-term care, and extensively in hospice. I'm also a book author for books specifically for my fellow hospice nurses, for my fellow holistic nurses, as well as caregivers. If you like watching videos that discuss those type of topics, including writing books and reviewing books that I've been writing and related topics, please feel free to subscribe, like, comment below. This is a non-judgmental channel. Today's topic will be a continuation of an ongoing series of looking at an overview of a book that's been in progress that I have the draft form completed, but today is going to be an overview of the cardiopulmonary compromise of the Hospice Clinical Pharmacology, Critical Thinking for Comfort-Centered Care. Now, before I go over that overview, I encourage everyone that's watching any of my videos to put into practice what I try to do daily. It's not being a mini-me, but what are you grateful for? Please think of at least one thing, if not several things, that you're grateful for today or in the moment. One of the common questions of hospice nurses and palliative care nurses, anyone dealing with death and dying on a regular basis, is how do you do it? How do you deal with death day in and day out? And many of us have had our own loved ones die. How do we deal with it? Well, for me, in addition to my faith in God, in prayer, and reading the Bible, it's having a heart of gratitude. We build resilience when we're grateful. So since the last episode, I'm grateful. My wife and I this past weekend, we went to a very rural area of Rockcastle, Kentucky, and we got to see a farm that was started a number of years ago when the farmland, this lady was able to buy her farmland at $500 an acre. So $500 an acre, but it's on a huge slope. So I'm going up to this farm. I am trying not to get sick, and my wife is driving, and I'm going like this, and I'm looking over, and there's the edge of the cliff. If my wife goes any more to the right, I wouldn't be making this video today. Well, we made it up the hill, and we got to see a farm that was created using, I hesitate using the word technology, but technology doesn't have to be your computer or your smartphone or a smartwatch. Technology could be a piece of machinery or a scythe. It could be a variety of things. So this lady who spent time in Peru and different South America areas and different areas overseas applied methodology of farming the land using permaculture and using horticulture techniques from different countries to deal in a very hilly, slopey environment to create rice fields and fields of different herbs. My wife's going to say I'm pronouncing that word wrong. And different plants that not only for her own benefit, but to feed the local community. And so I was so grateful to spend a couple hours touring her farm, and she built her own house from salvaged material and from dumpster diving. This was an amazing day to see that this weekend. And my wife and I got 2 of our fruit trees planted, and our vegetable garden's coming along, and I planted strawberries for the first time in my life. So I'm happy for that. So what are you happy for, and what are you grateful for? So those are some thoughts. Let me go over into the video about the overview of the cardiopulmonary compromise section, and then we'll come back for a quick outro. And I thank you so much for your. As we continue the review of the draft work of Hospice Clinical Pharmacology, Critical Thinking for Comfort-Centered Care, now on the cardiopulmonary compromise, looking at how heart failure and COPD, we have to have pharmacological considerations just for improved patient outcomes, focusing on comfort. So just going over the chapter introduction, along with the learning objectives for every chapter. And then we get into the meat of it. How does cardiopulmonary compromise impact pharmacology? So we do have altered drug distribution as cardiac output changes. We have third spacing of fluids. Tissue congestion impacts drug penetration. We also have changes in protein binding. Impaired drug metabolism and elimination. One of the things I learned early on, I did not start off as a hospice nurse. I worked in cardiology, where it was, and at some days it was as low as 60% cardiology, 40% med surge, maybe 50-50 on a weird day. On a good day where it was almost all cardiology, we're looking about 80 to 90% cardiology. And one of the lessons that I learned working in cardiology is like the movie, the Traveling Pants with the three sisters. Heart, lung, and kidneys are so closely interrelated. It's wow. And so there's perfusion changes, that takes into account as well. And that also includes the liver in terms of blood flow to the liver. Enhanced sensitivity to medications. We have unpredictable absorption. And what do we have to take into account? Well, when working with heart failure, we're typically dealing with patients who are taking diuretics. Those who are in end-stage heart failure, oftentimes, unless they're deprescribed before they come on to hospice, are typically on multiple blood pressure medications, ACE inhibitors or ARBs. And just as a side note, when we're talking about side effects, normally if somebody's on an ACE inhibitor like a lisinopril and they have a dry cough or angioedema, you're switching them to an ARB. Well, just because they're on an ARB does not mean that they're free from ever having angioedema or a dry cough. So you do have to keep in mind side effects can happen at any time. Beta blockers, typically for my end-of-life hospice patients, they've already been had their digoxin discontinued, but I've had a handful where it wasn't. So you need to keep in mind some of the toxicity impacts. COPD, we want to look at bronchodilators getting switched over to nebulized solutions. I've yet to meet too many patients that know how to use their inhalers correctly. It's usually far and in between. Give some just baseline parameters. And I'm going to actually, since this is a draft, I actually want to edit this to be more in line with the chapter after this when it comes to the oxygen. Clinical examples. So throughout this entire book, I try to go heavy with clinical examples. Every chapter after the first has several case studies in addition to the clinical examples. Key points for my fellow hospice nurses. Whenever you have somebody come on to hospice, statins should be among the very first medication that's discontinued. Almost every medication that is out there in the field has what's referred to as an absolute risk reduction. You'll hear of two percentages when it comes to pharmacology. You'll have relative risk reduction. So when they say, for example, warfarin is 95% more effective than aspirin, that's a relative risk reduction. It's in relation to something else. Well, absolute is not in relation. It's does the medication meet its goals? What's the absolute benefit of taking this? And statins, and this goes on if you're a healthy person or you're a terminally ill person, whether it's a torvastatin or rovastatin or simvastatin, pravastatin, whatever the statin is, the absolute risk reduction for all forms of mortality is, drum roll, 0.8%. So less than 1% reduction in lowering the risk of all forms of mortality for increasing side effects that will happen over time. Will. Because it builds up. And there are articles, the Washington Post did an article that toxic buildup. There's multiple articles out there that the longer you're on medications, it builds up. It's not just that you got a therapeutic dose, it's how long you have that going on. So you have increasing cognitive impairment that can lead to mild cognitive impairment that can lead to dementia, that can lead to worsening dementia. Increasing blood sugars that could lead to pre-diabetes, diabetes. I've already had brittle diabetes. If you've ever dealt with brittle diabetes, that's a disaster waiting to happen, especially when they're in hospice. And you're trying to keep them comfortable and you don't want to have the blood sugar controls tight. And then muscle aches and pains. These ones typically don't show up until years later, and they typically forget that it was the statin that caused the problem. So enough rabbit trails. Discontinue your statins upon admission, but also look at ACE inhibitors if they're asymptomatic. If they're typically if their systolics under 140, their diastolics under 90, you're going to be looking at discontinuing blood pressure medications. So it just goes over the limited benefits, minimal absolute risk reduction, secondary prevention as well. ACE inhibitors along with the Ys, some clinical assessments to look at, clinical examples, what we should be monitoring after getting approval for deprescribe. And sometimes at the end of the day, I shared this before, at the end of the day, we are not doctors, the doctor's in charge. But if the doctor's in agreement, we do want to educate our caregivers and our family members. If this is a facility patient, the nurses at the facility, what to look for and what to report to hospice. Going over why nebulizers are better than bronchodilators in terms of the inhalers. Why our first line of defense should be opioids when we're treating dyspnea. And as I share things, you are out in the field. I'm the author of this upcoming book. You are out in the field. Your clinical judgment matters more than anything I have to say. You're there, I'm not. So when I present this information, I'm hoping that it adds value to you, not to tell you your job. You know your job. I'm trying to provide tools of the trade to help you bloom in your job. So if you are reading this and anything, wow, I can use this, it adds value, or maybe you're reading the material and like, gee, I would handle it differently. Handle it differently. You're the one out there. I trust your clinical judgment because you got your feet on the ground. And I appreciate you and I value you. So going over again, practical implementations. How do we really assess for dyspnea, shortness of breath, while you can apply the 0 to 10 to everything? And I encourage you, I've yet to have a patient other than the mathematicians. I love the 0 to 10. They typically do better with mild to moderate severe versus giving it a 0 to 10. Why external oxygen is not always the answer. I still remember my well-meaning. I actually worked at the nursing home where this patient was at. Were a COPD patient, not on hospice at the time, on room air, but they went in and they put on the pulse ox, and I forget what the actual percentage was, but it was under 89. So they put on oxygen and they were treating for the percentage, and the patient became increasingly lethargic, and nobody's going, ta-da, it's the oxygen. They started her on hospice. I had this patient previously at home, and so I was able to recognize the symptoms of oxygen poisoning, got orders to titrate the oxygen down, got her on room air. She actually came off of hospice, and as far as I know, is still around. So oxygen is not always the answer. Be very, very, very careful on treating the numbers. I do have a book, uh, The Breath of Life, that looks at how can we as hospice nurses tell from an observation all over five senses, not just relying on the pulse ox. Some tools. This doesn't replace the book I mentioned, The Breath of Life. Hypervolemia. We've all dealt with fluid overload. This is a review. When does torsemide versus, I'm going to use the generic term because I murder the, I'm going to use the trade name because I murder the generic word, Mumex versus furosemide. But this goes over what's the differences between the three diuretics and when they might be advantageous in hospice, and then looking at prognosis. And as I mentioned before, my roots in hospice is rural hospice. Drive a half hour, an hour, or more to see a patient, and not always able to get labs. Um, that's its own story. If you do better for your hospice, I'm glad for you. But I try to write with my rural hospices in mind and give you the tools of the trade that if you don't have access to labs. My opinion only, I think we're better nurses when we could use all of our senses and what's in our nursing bag versus relying on numbers. In non-pharmacological methods, again, back with the clinical examples, I am a big fan of small portable fans that's directed at the face of the person, typically at the lowest setting. When I talk about a portable fan, I'm talking about a fan whose blades are about the size of your palm. So let me just, so this is an example of a small portable fan. I use that to help cool my office router. But we're talking about something small. I'm not saying buy this, but something that could be preferably on a nightstand attached to a bed rail, pointed at the left or right cheek. It sparks, it triggers the trigeminal nerve. It really helps with breathing and lowering anxiety. I've had heart failure patients say, gee, that it kept them from needing oxygen from their point of view. Then we're getting into our case studies for this chapter, looking at using opioids and what that might look like. After you're reading this book, you're going to get sick and tired of the S bars, but it's just drilling in. Interventions and rationale. Again, going over nebulizers versus inhalers. And yes, you do have to have your patient buy into any and all of this. So it's not just that the doctor has the final say. We always have to remember and respect patient autonomy. Our patient, or if they're not able to speak for themselves, the medical power of attorney or the family spokesperson, they have the first say. And in the end, the last say. And I'll leave it at that. Interventions and rationale. And on some of this, yes, I'm scrolling down rather fast, but I'm hoping this book will be available by the end of this coming week. We're now in the middle of April 2025. Managing fluid overload and heart failure. This is one of the chapters with a lot of case studies. They all have case studies, some more, some less. What about loop diuretic selection, where maybe they're not on one? Considerations for whether it's furosemide, which is Lasix, torsemide, or again, I'll use the trade name Bumex. Yes, I get tongue-tied. And looking at the S bar, again, interventions and rationale. My goal is to help all you and me as the writer, you as the reader. How do we improve our critical thinking to enhance patient outcomes and then hopefully reduce everybody's stress? I know the longer that I do things, whether it was in cardiology, long-term care, hospice, I became comfortable in my own skin. It was just easier to deal with. And then here, I still remember my one of my heroes. I have several heroes as patients. Keith, who had heart failure, and his wife Teresa, were towards the end. The diuretics were failing, and so we have to be prepared for those worst case scenarios. And this book is not going to handle every worst case scenario. I am not God. I will never be God, but this is just to give you some tools in case you've not run into it. I have. Maybe you have it. And maybe you have, and between the two of us, we can combine our heads, and you might come out with something even better than the ideas brainstormed in this book. So again, how we handle that. One of the things that's not mentioned in this book, but I'm going to put it out here, is if you have the worst case scenario, you've done everything you can for symptom management. Always remember that in the United States of America, it's legal in all 50 states to do palliative sedation. Yes, you have to have the patient, the power of attorney, and a doctor buy-in. And yes, you have to train the caregivers on what to do unless you're doing continuous care or they're in a hospice facility. But you can do palliative sedation to have them sedated until the very end, worst case scenario. And I do mean worst case scenario. Managing air hunger, that's one of the most common fears out there for anyone who has respiratory illness or heart failure. What if I can't breathe? So we're looking at one of the assessment tools that are out there for determining how bad things are. And then here's where to take it. And as we conclude this chapter, every chapter I like to get into discussion questions that you could have with your team, practice scenarios that you can have with your team, as well as Socratic questions. I don't know if one day I'll ever be able to turn this into CEU courses. That's a long-term goal of mine. But even if I can't, you're prepared with this. That's my goal. Thank you for watching this segment. That concludes the cardiopulmonary chapter. At the point of this filming, I do have the rough draft of the entire book, including all the appendices written. So Wednesday's episode will be looking at how do we view things when we have admission lab data, and how do we project where things are going if we might not be getting any further lab work, and then how do we interpret things without lab work at all. And then Friday will be, here is the last chapter of the book, which is dealing with challenging provider orders. It's always a sensitive topic, but we are called to be advocates for the patients we serve. And in that overview, I'll also show you the appendices that are written. And come Friday. If anything changed, I'll be doing some updates in between. But that's the plan for the rest of this week. I do thank you for your time. Like if you like what you're seeing, non-judgmental channel. If you have questions, even if it's a matter of you're not going to buy any of my books, but you're curious as to being a book writer, or you have a question of hospice in general, or what's it like to be a hospice nurse, ask questions. My main disclaimer is I don't know it all, obviously. I don't have a relationship. There's not a nurse to patient relationship that we're forming. I just like helping people. And if I can help you bloom in any way, shape, or form, I'm good with that. Thank you for your time. God bless. And